So, good morning. My name is Piotr Rutkowski. It's my great pleasure to tell some words about the precision oncology in soft tissue sarcomas. I represent Department of Soft Tissue, both sarcomas and melanomas in Maria Sklodowska-Curie National Research Institute of Oncology in Warsaw. And we are one of the reference centers in European Reference Network, EURECAN, for rare tumors, for sarcomas, and also I'm involved in handbook of precision oncology. So I will focus on soft tissue sarcomas, including gastrointestinal stromal tumors, or GIS. As probably you know, it's a family of rare tumors, and it includes approximately 100 different entities. And the histological diagnosis is based not only on the morphological and immunohistochemical characteristic, but also very often includes molecular tests, starting from FISH, so fluorescence in situ, but more often it is utilized NGS, next generation sequencing, because it's much more sensitive, and sometimes we have to find the specific alteration. Why it is so important? Because morphology per se does not distinguish many of the subtypes, and in about 50% of soft tissue sarcomas exist specific characteristic molecular alteration, mostly as a fusion genes. So we have this kind of alteration, and sometimes we have also specific mutation, especially in GIST. It is important because the primary treatment of soft tissue sarcomas, usually it's kind of combined treatment consisting of surgery with plus minus radiotherapy, and sometimes neoadjuvant chemotherapy is considered for localized GIST. However, in metastatic unresectable setting, we have to be more precise with selection of the proper therapy, both classic one, based on this subtypes of soft tissue sarcomas, but also we use molecularly targeted therapy. One of the molecular targeted therapy is anti-angiogenic treatment, pazopanib, which demonstrated statistically meaningful improvement of progression-free survival over placebo in patients with metastatic non-adipocytic soft tissue sarcomas. It's one of the drugs used for different types of the tumor. But we also know that there is a specific alteration which can occur very rarely, but occur in sarcomas and in GIST. It's discovery of neurotrophic tyrosine receptor kinase, so NTRK gene fusions, occur in up to 1% of soft tissue sarcomas, with exception of the infantile fibrosarcomas, where it is present in more than 90%. However, in situation when we detect this NTRK fusion, now we can use NTRK inhibitors, larotrectinib and entrectinib, with high efficacy. So there are other soft tissue sarcoma subtypes where molecular targeted therapy can be utilized. A fine example is dermatofibroma protuberans, DFSP, which is usually locally invasive tumor, but sometimes it can be metastatic on primary unresectable, and because of the translocation involving platelet-derived growth factor beta, so PDGF beta, which is found in almost 100% of cases, imatinib, which is drug against PDGFA, are X with prominent efficacy And it is treatment of choice for systemic treatment of patients with advanced DFSP and also fibrosarcoma to DFSP, with overall response rate up to 50%, but clinical benefit of 80–90%. It can be also the option for neoadjuvant therapy or locally advanced DFSP. In PEComas, it's the regulation of mTOR pathway, and these drugs, mTOR inhibitors, are used in this type of the tumor. Very interesting rare sarcoma subtypes is inflammatory myofibroblastic tumor, and it's at least 50% of cases it's characterized by ALK rearrangement, and ALK inhibitors demonstrated response rates, objective response rate, it's more than 50%. And this is treatment of choice at advanced cases. In epithelioid sarcoma, it's chromatin remodeling complex disturbances, and any dysfunction results in constitutive EZH2 activation, and EZH2 inhibitor tazemetostat is first-in-class drug approved for this type of sarcoma. Tenosynovial giant cell tumor, it is also known as pigmented villonodular synovitis, PVNS, which is rare locally aggressive mesenchymal neoplasm, and it is related to aberration in colony-stimulating factor 1, CSF1. So CSF1 receptor inhibition is now of the targeted therapy in locally advanced cases. Very unique and very specific type of sarcomas. Maybe I will mention also about some others, like solitary fibrous tumors. Anti-angiogenic drugs are utilized in alveolar soft pulse sarcoma. Also, anti-angiogenic drugs like sunitinib or cediranib are treatment of choice in metastatic setting, but very unique and distinguished kind of sarcomas are GIST, so gastrointestinal tumors, which is also heterogeneous group of the most common mesenchymal neoplasm of the gastrointestinal tract. And from the beginning, the understanding of molecular mechanism of GIST pathogenesis included the discovery of two oncogenes, which are mostly involved in the pathogenesis, KIT and PDGFRI. And it led to the development of systemic therapy, which is kind of the model of targeted therapy in oncology. There are also so-called wild-type GIST, sometimes related to NTRK aberration or SDH aberration or BRAF, but generally the most important are KIT or PDGFRI mutations, and imatinib was the first systemic agent introduced for treatment in early 2000s in metastatic unresectable setting with very high efficacy, with disease control rate at the level of 80%. And now also it is used in adjuvant indication, adjuvant setting for 3 years after resection of high-risk primary GIST, improving relapse-free survival and overall survival. Generally, also neoadjuvant imatinib is standard treatment strategy in locally advanced and or marginally resectable GIST with sensitive mutations. In the progression, after progression, in the second line, the standard drug is sunitinib. In the third line is regorafenib. In the fourth line is ripretinib. Recently, also in patients with imatinib-resistant PDGFRA D842V mutation, avapritinib as a highly selective oral PDGFRA inhibitor was approved with clinical activity of more than 90% overall response rate of patients with unresectable metastatic PDGFR D842V mutant GIST patients. So in rare situation, as I mentioned, and TRK inhibitors can be also utilized, but it's very rare situation. So generally, to summarize, of course, there are huge developments in the recognition of molecular pathogenesis of different sarcoma subtypes, so different targeted therapy are under development. But the most important message is that this kind of the tumors should be diagnosed and treated in reference centers with very experienced pathological team and also molecular biologists. And it is important for the diagnosis, for choice of the treatment, and also for targeting treatment in advanced cases. So thank you very much for your attention.